So I'm a board certified psychiatrist and I've coached over 160 PMHNPs get confident in psychiatric diagnosis, treatment, and master their clinical cases so they don't feel imposter syndrome. And so in this video, we're going to be covering BPD, borderline personality disorder, versus bipolar. So this is a mistake that a lot of psychiatric providers make in being able to diagnose it correctly. And this is very important because if you have the wrong diagnosis, then you're going to have the wrong treatment. So let's go through exactly how to tell these apart, and so you know how to treat the patient correctly with them. So there's things that make these two easy to confuse because they have some commonalities. So they have some common features. By and far, the biggest one is mood lability. So you often hear in the common clinical term, like, hey, oh, this person's bipolar, like their moods are up and down. That we should know is different from a person's moods being up and down than from a clinical bipolar, which we'll get to, but they both involve shifts in mood. So that's a very common thing. Both, so two, they have impulsivity. Both BPD and bipolar patients are notorious for having impulse tendencies and doing things that they regret later down the line. Three, so trauma histories. They both can often have trauma histories. Now, BPD is more associated with trauma history than bipolar, which is more of a genetic thing. But however, they both can have a trauma history. So just one having a trauma history doesn't tell you if it's BPD or bipolar. And lastly, stigma. They both can have stigma associated with them. Like no one wants to be called BPD and no one wants to be called bipolar either. So that's a common thing. But however, there's a lot of differences that each have. So now if we get to the diff, so we'll do BPD, we'll do bipolar. And the way that I like to think about it is it's broken down into different categories. So when we have mood shifts, both can have mood shifts, but it's different. So with BPD, the mood shifts are in minutes. So this is very key. Like in a BPD patient, they might be talking with someone, then they get upset about something, then they get angry, but then maybe a couple hours later, they're fine. It's integrated with their personality, borderline personality disorder. So that's why it tends to go up and down, associated almost like with the wind. Small things will irritate them a lot more than the average person. Whereas for bipolar, it's days to weeks. So in bipolar, people can enter hypomanic episodes, manic episodes, or like episodes that don't meet the full criteria, but they might still last a day or two. And so this is longer. And you can have rapid cycling as well in bipolar. But the point is that the mood changes are slower. So they're more in like discrete patterns. So someone might have a manic episode where they're grandiose and feeling really good, but then they might also be a mixed episode where they're feeling angry, irritated, or they could have the depressive episode, which might last them a week or two. Whereas in borderline personality disorder, a depressive phase might last a couple hours, maybe a day or two, but it doesn't stay. Triggers. So they have different triggers. So the triggers in BPD are often interpersonal. Interpersonal. So this means it has to do with relationships, stuff that happens to them. This person said something, this person did something, this person abandoned them, this person they feel is talking crap about them. So breakups, these type of things tend to institute the mood shifts in BPD, whereas in bipolar, it's more biological and more temporal. Bipolar mood shifts are associated with biological changes. So, decreased sleep is a common change. So, that can be a trigger. Hormonal shifts, temporal seasonal shifts. So, with spring, there's been a resurgence with bipolar sometimes because of the new onset of the sun, and that tends to activate a lot of people into mania. And so, that is a big difference there. So, insight. So different people, they have different type of insights. So with BPD, the insight is often poor. So this is why BPD can be such a struggle for patients to deal with and for their family members and collectives. So for example, I have this patient who says that his sister, multiple clinicians suspect that she has BPD, but the patient is not willing to acknowledge it. So she's doing a lot of destructive things, like she's doing this behavior called splitting, which is she's telling the family members of the patient one thing, and she's telling the patient a different thing, and then she's creating drama saying that the patient didn't buy her a birthday gift, but the patient did buy a birthday gift, but it came late in the mail. So she's telling the parents this, and so now basically like they're arguing amongst each other. So, but the point is that she has poor insight, so she's not realizing that this is a condition. So oftentimes BPD patients, they don't know why they're behaving that way. They just feel like, okay, like I'm just angry. So they believe in their emotions fully and they will. But the point is that the insight is often poor. And that's what makes treatment difficult. You can't do treatment like DBT if they don't even believe that there's an issue in the first place. Whereas with bipolar, it's poor during mania, usually. But it's pretty good in euthymia. So when they're like in a normal neutral state, and depressive times. Oftentimes, like they can understand that, okay, I feel depressed and it's because of the bipolar I have. So the insight can be better. So it can be poor during a manic episode, but it can be good in outside of episodes. And so this is why for bipolar, if they're able to stick with their medications, usually the treatment outcomes are better. Sleep changes. So this can vary. So, I mean, their sleep could just be good like other people's or bad like other people's. It really, there's not much correlation between it. Of course, when someone gets poor sleep, then they're going to have more mood lability. Like that's just a natural thing. So, but it's not like a trigger for anything. Whereas for bipolar, a diagnostic sign for it is decreased sleep. So decreased sleep during mania is a sign for bipolarity, because then decreased sleep and functioning very well during that decreased sleep is a sign of mania. And then if we talk about SI, or self-injurious behavior, self-harm, this is very common with BPD. So suicidal threats, SIB, the self-harm behavior, self-injurious behavior, very common. Threats of this are very common as well. Day to day it can happen, whereas in bipolarity, it's more episodic. So it could happen during a manic episode, it could happen during a depressive episode, but it tends to be, like I said, in episodes. It's not more of a day-to-day thing. So that's the difference. And the course of it. So the course of BPD is chronic. So what this means is that like this is ongoing. So it's not like it differs from time to time. It's just ongoing. Usually starts in adolescence. So teens. Whereas for bipolar, the course is also episodic as well, and usually starts in 20s. So that's the difference between BPD and bipolarity there. And the medication response. So patients will respond mild to moderate to meds. Meds aren't a primary treatment for BPD, but rather they can help some of the affective instability. Whereas for bipolar, the med response is pretty good and it's targeted. For example, things like mood stabilizers, things to target mania, like antipsychotics, the mood response is a lot better studied and there's a lot more robust of a response with bipolar than there is with BPD. So now when you're trying to figure this out, which does the patient have? There's some questions that you can ask them to help hone in. And so here's some of the ones that I like to go with. Number one, by far away, is the timeline. Ask them what the timeline is. So if they say that, yeah, like my mood's up and down and it's all over the place, then that's cueing you in for BPD. Whereas the patient might say that, hey, I remember like I had this one week where I felt really good, but then I had a couple weeks where I felt really bad. And then sometimes I feel fine. And then you elucidate, does it last for days, weeks, months? Usually a depressive episode will last longer. So patients will commonly say like they might have the hypomanic episodes or manic episodes like 4 days, 7 days, etc. But then the depressive episodes could last a month. So, but you try to figure that out. And once you like drill into it with them and you get granular, patients are often, they have some insight in that, like they recognize those shifts. But keep in mind that when patients are younger, so in their adolescence, the bipolarity is not as discrete. So it can actually resemble BPD. And so this is a clinical pearl. So for adolescents, it can resemble BPD because it's a lot more labile, but the mood episodes tend to start discreting a lot more when it becomes to the early 20s. So as the course of the illness develops. So in the prodromal phases, it may not meet the full diagnostic criteria for bipolar. So timeline, triggers. So triggers are another important consideration. Knowing what the triggers are for a medication or for the episodes are super important. Is the trigger another person? Is it when there's an event? Or is it maybe lack of sleep? Trying to elucidate that. With bipolar, they might not be aware of a trigger, but with BPD, they might be like, oh yeah, like this thing happened, or she said this, or he did this thing, or, I had a breakup. So that is often a trigger. But remember that stress can also be a trigger for both. If there's a lot of stress, then that can cue someone to get into a manic episode. So it's not foolproof by any means, but trying to elucidate the triggers are very, very important. So, how the length, right? We talked about the timeline, how long the episode lasts. So that's really important. Another thing is family history. So BPD is often trauma related and trauma triggered. And of course, there is some family history. People may have been diagnosed, but the people that we might treat now, BPD was not a very common diagnosis back then. But bipolar was given a lot more frequently. Like that's what I've seen. So if a patient tells you that, oh yeah, my mom or my grandma had bipolar and they were on lithium, for example, I always ask what meds they were on too if the patient knows. So if they say stuff like lithium, Depakote, or like Zyprexa, and if you know the dose and ask them that, that can help you cue you in towards the bipolarity spectrum if there's a strong family history of it. But just remember that that's not foolproof either because BPD was not as diagnosed back then, and a lot of BPDs may have been misdiagnosed as bipolar. And mood charting. So mood log. So this is something that you could ask on follow-up visits if you feel that the patient is not fully sure. You can ask them to keep a mood log, just a day-to-day diary of their mood. So if they see that their mood's hopping down a lot of the time, then that's more likely to be BPD, versus if you start seeing patterns, then it's more of a discrete biological thing like bipolar. Just like with a menstrual cycle, people can have different mood shifts related to the cycle. And so you can actually track those based on the cycle. So bipolarity is similar in that regard. So real briefly to cover on treatments, we'll do a full separate video on this later, but To treat BPD, so they have different treatments. So for BPD, it would be DBT. So dialectical behavioral therapy, that's the number one. Basically, DBT teaches patients how to be more mindful, more emotionally resilient, more in tune with their thoughts, so that way they can modulate their responses better, more relate to other people better. And I'll have a full video explaining DBT in depth, but that's the whole point of DBT. And then two is adjunct meds. So this is SSRIs, low dose antipsychotics, maybe some mood stabilizers, low dose. But the whole point is that you use meds as an adjunct to help some of the symptoms. Whereas for bipolar, so mood stabilizers, and antipsychotics. So these are the mainstay. Like that is what you use to treat bipolar disorder. And some SSRIs too, if the mood has been stable, or to address some of the bipolarity spectrum. But the whole point is that meds are a big part of bipolar treatment, whereas for BPD, they are not. Of course, in bipolar, you also have lifestyle changes. I had another patient who was getting very triggered by alcohol. And once we discerned that, then yeah, alcohol as well. So, for example, I had a patient who had a lot of mood lability, and she suspected some BPD traits, and I was trying to assess her. She described this incident where she found out that a family member was part of their ancestry, and because of this, she spent the week tracking down this person. She went to their house, and she had never done something like that. She said she was obsessing over this, researching everything about them. And so from that, I realized that, oh, okay, like I think there's a bipolarity spectrum going on. Because she also said that when she drank alcohol, she would do things like have crazy intense rages and moods. She would get in, it was not when she drank alcohol all the time, but rather when she would have periods of crazy intensive moods, they were always alcohol triggered. So that's what made me suspect that there was a bipolarity spectrum, especially when she did that impulsive action as well. So yeah, but other than that, so those are the main differences. So really keep this chart in mind, so that way when you're trying to assess between your patients, you can figure out which one it is. And so I hope this is helpful. And if you want more coaching like this, if you really want to take your psychiatry knowledge, your skills to the next level, so that way you can treat patients better and be more confident, reduce imposter syndrome, help patients get better quicker, get promoted faster because you get recognized more strongly for your clinical skills, then definitely consider joining our coaching academy for PMHNPs. We've had over 160 joins so far as of time of this recording. So I think you'll find it very helpful if you really want to take your psychiatry knowledge to the next level. But otherwise, I will see you in the next video.